think we're ready, Meg.
Okay. Thanks very much, and good afternoon or good morning, depending on where you are located today for our webinar. And welcome to today's webinar, Antidote to Pandemics, Population Health Leadership in Action, hosted by all of us, the Action Collaborative on Business Engagement in Building Healthy Communities. I'm Meg Guerin-Calvert and co-chair of the collaborative, and I welcome my other co-chairs to this session as well. The collaborative is an ad hoc activity associated with the Roundtable on Population Health Improvement, which is itself a convening activity launched in 2013 by the National Academies of Sciences, Engineering, and Medicine. The collaborative is a flexible and action-oriented group that welcomes all interested organizations and individuals, and really excited to have so many attendees on our call today. Our purpose is to catalyze and facilitate private sector partnerships and actions of business, health, community, and public sectors to work together to enhance the lives of workers and communities by improving the nation's health and wealth. And that is no more important ever than it is today with the COVID pandemic and going forward. This is the 6th in our 2020 series of webinars, and it's the 4th webinar featuring a response to COVID-19. Our webinar series has been shaped by the current public health crisis and a desire to try to share great examples from across the country. And that is what we have today on this webinar. Our speakers today are Nick Maggione, Dr. Wilma Wooten, and Carrie Riccatelli, all from the County of San Diego Health and Human Services agencies. Just to let you know, if you go back to the announcement, very thorough bios are provided there. We encourage you to look there. We want this to be a session where we'll all learn today from what San Diego, building off of Live Well San Diego and going further, has done with their collaborative specifically and in a significant way to address COVID-19. Wanted to have it to be interactive and an opportunity for you all to ask questions, post items, post comments. So a few quick logistics. The webinar is going to start with our speakers in just a few minutes. They're going to share with us their story, what they've done, the actions, up until about 1:55. We'll then turn it over to a Q&A session that I'll moderate. And we'd really appreciate it if you could put questions during the speakers talking in the Q&A function, and or you can use the chat function to provide comments, links, and so on there. The session is being recorded, so please understand that any questions you may submit might be read aloud and included in our recording. And we will be posting in the upcoming several days the recording and or the slides that you're seeing, so you can look forward to seeing those. And as you just saw in the chat, if you do have any technical issues, please do look at the chat. It's got the contact information. And with that, I'm really excited to turn this over, Nick, to you to get us started. Welcome.
Thank you, Meg, and good morning, good afternoon. I hope this finds everyone in good health and safety. Our deepest appreciation to the Action Collaborative for what you do for our nation, and to Alina at the National Academy of Science for Population Health, and the opportunity you've given us to share, as Meg said very well, our story, the journey that we're all on in protecting our lives of our community. And we're going to do it in sharing, but as I've always said, we have much to learn from each other. So we are really eager into the question and answer period as well. We laid out 4 key objectives for our presentation. And as Meg mentioned, my colleagues, Dr. Wilma Wooten, our Public Health Officer and Director of Public Health Services, and Carrie Riccatelli, our Director of Strategy Innovation for the Health and Human Service Agency, and I will be doing this kind of team approach. As we thought about sharing our journey, we broke it up in these 4 learning objectives, and one was really talking about what is the framework we're using to respond to the COVID-19 pandemic, followed by the actions and approaches we're taking, almost as what's been the use case in a very broad way down to some individual actions we've taken, and we've learned from both from successes and also from areas that we have not been successful. So we'll be as candid as possible with you. And the third objective is to identify how we went about identifying and engaging key stakeholders. And it's just beyond just key stakeholders. These are rapid ways of communication channels to create this kind of force multiplier of trusted messengers in a way that we have to get to our 3.4 million population and how we went about that. And Carrie Riccatelli will be sharing about that. And then we'll end up with, wrap up with what we saw as and have seen as key lessons that Dr. Wooten, myself, and Carrie will be sharing and still learning as we go through this journey. So I'll start with the first aspect of the framework that we're using. As Meg said, really for us, it's our vision. In 2010, we launched, in July of 2010, now over 10 years ago, we launched our population health strategy, a vision, which we call Live Well San Diego. And it's predicated on really this triad approach of building better health, living safely, and thriving. And I'll illustrate that very quickly in the next slide. But it really is the blueprint that guides not just the work of the Health and Human Service Agency, and not just the work of the County of San Diego government, but really guides the work and the vision for our entire County of San Diego, as you will see, of how we have been with this social movement driving well-being for all San Diegans. In the next slide, this is our action framework. We start with the clear vision. We talk about how we built and continuously refine our population health strategy with Live Well, is that it's evidence-based policy driven by data focused on our operations with a strong emphasis around public-private partnerships. And this is predicated around how we look and measure and engage, where we're having impact to where we're not. So it is a collective impact model that we are still using to this day. And I won't go into all the elements. You can go to our website and go into very deep in all components from the vision all the way down to our indicators that we have. But the key to this plan is the actually implementing of it. And for us, from day one to this day, and it's even reinforced more even today, is that it had a very strong health equity lens in guiding our work, knowing there were areas of parts of our community that were not living well to other areas. And so this becomes very powerful for us because it really is about adding years of life expectancy and quality of life. Now, when we are talking to the issue of COVID-19, we have been blessed beyond blessed in San Diego in that for the past 10 years, we built our antidote, not knowing about COVID-19, but the antidote to a pandemic, and that is population health. And so we'll move into then discussing how Live Well has been put in action. And that leads into our second learning objective about what actions and approaches we've taken both from a broad scale down to a more transactional kind of effectiveness. And our champion leading this charge is our Public Health Officer, Dr. Wilma Wooten. So she'll take it over from here. Dr. Wooten.
Thank you, Nick. Good morning, everyone. From the very start of the pandemic, the county utilized its incident command structure to manage COVID-19. And this was a best practice that was implemented during our previous public health crisis namely the hepatitis A outbreak that occurred in San Diego. ICS is comprised of representatives, including a legislative liaison to track and advise on state and federal efforts rolling out in response to COVID-19. Our county Human Resources Department, or HR, to address the needs of our county staff and bringing on additional resources as needed. Our Joint Information Center to ensure there's an accuracy of information being disseminated to the public. And in addition, safety, recovery, and county council representatives that advise and plan for the future. Now, as you all know, ICS is composed of sections. We refer to it as FLOP, finance, logistics, operations, and planning. And in addition, as a after-action report from our 2003 wildfires in San Diego, it is also composed of another entity called a Medical Operations Center. The Medical Operations Center was stood up to liaison with our healthcare system to address any needs that they have. Now, in this next slide, what we want to show is a timeline of sorts of some key milestones. As everyone knows, the novel COVID-19 virus, or the novel coronavirus responsible for COVID-19 disease, was detected in Wuhan, city of the Hubei province in China in December 2019. Since then, the World Health Organization and the U.S. Departments of Health and Human Services declared COVID-19 a public health emergency. So on January 30th, WHO declared the outbreak for COVID-19. On January 31st, HHS Secretary Alex M. Azar II declared a public health emergency for the United States to aid the nation's healthcare community in responding to COVID-19. And then on February 14th, here in San Diego, we also issued a declaration of a local health emergency as well as proclaiming a local emergency. Since then, the virus has spread rapidly across the globe, resulting in WHO declaring a pandemic on March 11th. And then on March 19th, the state of California, public health officials also issued an order for everyone living in the state to stay home, except for those that were conducting essential services. So over the following months, there were updates to the state's health officer's order as well as our local health officer's order. And on April 28th, the county rolled out its T3 strategy to aggressively address identifying individuals throughout our county that were COVID-19 positive. Now, in the next slide, we want to share with you 5 major approaches that were deployed to address COVID-19. The county has taken these various approaches to help slow the spread of the virus throughout the community to decrease COVID-19. So the 5 approaches include containment and mitigation, basically implementing non-pharmaceutical interventions, given the fact that we don't have pharmaceuticals or vaccines or treatment to address this disease. And these were deployed to, as we commonly hear, flatten the curve. Also, we leveraged our Live Well San Diego strategy, and Carrie is going to talk about this, calling on our sector partners to help educate them and to get feedback as needed to address our response. Then we will talk about federal and state data-driven metrics, and then T3 will be discussed by our agency director, Nick Mascione, and then I'll also cover the attestation and containment plans that were submitted to the state for our jurisdiction to be able to open up. So in the next slide, this is the adaptive response to COVID-19, and as you can see, it is composed of 3 components: disease control that is implemented throughout the containment and mitigation phases, and then the non-pharmaceutical interventions that began at the mitigation phase. While we are implementing these non-pharmaceutical strategies, again, these help to flatten the curve to give us time until treatment and vaccines are developed. In the next slide. So we commonly hear about the flatten the curve, and we feel San Diego actually did a great job at doing that. And in the next slide, the whole purpose, again, for flattening the curve is to help lessen the impact on our healthcare system, so we are not overburdened and we do not overrun our hospital capacity, namely hospital beds as well as ICU beds. Now, this is our classic epi curve for San Diego County since the beginning of the pandemic. Early on, San Diego actually had a nice run with individuals that were coming from Wuhan, repatriates. And we had experience working with our local Navy military system to manage those individuals. So that really was a nice learning ground for what was to come. And we had our very first case of COVID-19 in March, actually March 9th. And as you can see, early on, when testing was getting started, we were under 100 cases a day. And then we increased, but on June 12th, after orders or from the state were issued to open up, we then saw really an exponential increase of cases in mid-June through July, which resulted in us dialing back the dimmer on various businesses that had opened so that we could try to get our arms around the increased number of cases. We had the highest number of new cases reported this past Friday at 634. In the next slide, these are the federal and state data-driven metrics and the strategies we use, calling on the guidance from the White House, guidelines for opening up America again, and then the California's roadmap to modify the stay-at-home order. In the next slide, reviewing the White House guidance, there were 5 metrics across 3 categories: symptoms, cases, and hospitalizations. And the symptoms were related to influenza-like illnesses reported in the past 14 days, as well as COVID-like syndromic cases reported in the past 14 days. Both of these are cases or individuals that would present to our emergency department. We monitor influenza year-round, and we started monitoring COVID-like symptoms that were presenting to the emergency department as well. For cases, we chose positive tests as a percent of total tests within a past 14-day period. We've since modified this to look at the past 7 days because of the increase in community-wide spread of COVID-19. And then in the hospital category, if you can go back, yes, that was focusing on our hospital capacity, and then the other component under hospitalizations was also focused on testing. Testing was also a big component for the state, and there were metrics that were created. For stage 2, 1.5 tests per 1,000 population, and now we're in stage 3, which the target is 2 tests per 1,000 population, which is approximately 6,600 tests daily, and Nick will talk about that in a moment. Now, this next slide is a crosswalk. Actually, the next slide is basically the 6 metrics from the state, focused on epidemiology stability, protection of stage 1 essential workers, focused on PPE, testing capacity, similarly, as I've explained already, containment capacity, hospitalization capacity, and vulnerable populations. And the vulnerable populations we'll get to in a few minutes, but it was focused on individuals in congregate care facilities, a homeless population, as well as those in the correctional facilities. And then we also had to submit for our attestation applications triggers that we would develop to determine if we would take action or change our health officers' orders. In the next slide, this is just a crosswalk between the state and the White House metrics. If we look at the prevalence of COVID-19 in the community, that included metrics number 1, 2, and 3 from Opening Up America again. The stability of hospitalizations was metric number 4, and testing as well as contact tracing were bundled, and that will be a part of our T3 discussions. Those were related to the White House metric number 5. And then the remaining 3 metrics, personal protective equipment, again, PPE, our health care surge capacity, and then public health guidance in place. That's basically related to health officers' orders to stay home. Next slide. Now, briefly, I'm just going to share with you just some information about where we currently are before I turn things over to Nick. So currently, we are at 2,435 cases in San Diego County. We have slowly been going up in the number of cases between the ages of 20 to 49 years of age, and that really started to increase since the beginning of the outbreak, starting at about 50% and now at 59%. We look at our information for cases as well as for deaths through a health equity lens, and Nick will talk about that in testing as well in his section, but we break out all of the cases by the prevalent races and ethnicities to show how the cases are distributed across the community. We also post on our website, coronavirus-sd.com, all of our cases by zip code and also municipalities. So for today, we have, and this is data from yesterday, we had over 2,000 individuals that have been hospitalized, and of that number, 575 are in the ICU, and we have a total of 478 deaths. Going on to the next slide, and talking of deaths, the total number of deaths, the average death is about, the average age is about 78 years, where the average age for all cases is about 48 to 49 years of age. Let's go to the next slide. This slide is our triggers, and it is stratified into 3 categories, which is epidemiology or surveillance, then healthcare or hospital capacity, and the third category is public health or response. And there are 13 metrics across these 3 components. And this is our trigger as of yesterday, and you will see that there are 3 metrics that are abnormal: our case rates, our community outbreaks, defined as 7 or more outbreaks over the past 7 days. We have 16. The case rates, we want it to be no higher than 100 cases per 100,000 population. And then trigger number 11, we are now at 8% of for case investigators, and we are bringing on new staff. We currently have about 223 staff that are on board, and we are bringing on at least another 200. So in the next slide, I just want to attestation and containment plans. The same metrics that I already shared with you, we submitted our attestation document on the 19th of May, not the 29th, and it was approved on the 20th. And I just want to focus my last 20 seconds on vulnerable populations. And these were the vulnerable populations in the next slide that were identified in the attestation and containment plans. And we also borrowed from our testing priorities document that was developed in April 22nd, and if you go back, we borrowed from this document to include other at-risk populations for testing in our vulnerable populations and develop a plan for our attestation and containment plans to focus on these vulnerable populations. Now I'll turn it over to Nick to talk about T3.
Sure. Thank you, Dr. Wooten. And I think several points were reinforced about how we go about clearly being not only data-driven, but really the whole equity lens. So when we put together our response, and much of what Dr. Wooten talked about, and looking at who in our community was being more adversely impacted, you saw the slide for Latinos, Hispanics. Grounded then in where people live, work, play, age, mattered immensely of how we were designing the engagement of our T3 strategy. And what really separates the work from the beginning for us for testing was, it wasn't just popping up a tent and going and doing a test. We wanted to make sure that as people came in for testing, they had a whole experience, particularly as people came in with the fear and the unknown, and then being positive of how do we go about in a meaningful way, a culturally responsive way, of then engaging with them, knowing that we had to then conduct a whole disease investigation and tracing and really speed and accuracy of finding those folks so we could slow the spread of COVID-19. And then for some of them, not knowing where to go. And in our community, really proud of what we did really from the onset of securing, it was a 1,200 hotel rooms, where we call them public health rooms, where we give people at no cost a place where they can safely quarantine or self-isolate for 14 days with the wraparound wellness check, mental health, food, and support, so they can heal and rehabilitate during that time safely if they don't have a place where they can go. And so this design is a very integrated approach. So next slide. So from us, as it's been stated, we wanted it to be not just a guiding principle, but built into design of T3 and everything we did about how we were addressing not just the disproportionality, but very importantly, this issue about health inequities. Something I know that the Action Collaborative holds dear to heart, and the work that we do with our business partners and many of the other partners, and Carrie will talk about that as well. But I'll illustrate for you, next slide, how we went about thinking of accessibility. In the reopening, there were guidelines from the state that we needed to be testing sites within a half-hour drive in our urban areas and an hour within our rural areas. But we went beyond that. We thought about our population, and some could not be in the drive-up ability to walk up to a site. Some had to drive. Some we had to go to. Dr. Wooten talked about, we talked about our vulnerable populations. We had to go to our long-term care facilities. We have 1,500 of those, of which 86 of those are skilled nursing facilities. We had to go to our correctional care facilities. So these nursing testing teams, which are public health nurses primarily, would go to places. We also developed an allegiance and partnership with our first responders, our CAL FIRE, it's called. These are our emergency medical services who, as a waiver by the state, were allowed to give the test. And we are talking here about the diagnostic test. This is the PCR test. We're not talking about serology. That's really the focus where we have been. And we wanted to make sure is that we looked at multiple access points at any given week, over 30 different sites, led with the county and the state of where people can go for free, zero cost tests based on the criteria people being of the high priority populations. Next slide. So we looked at what our data was telling us, and this is our county map, and you can see the darker green is a higher prevalence in terms of our higher rates, and that's our South region. We call it our South Bay area. And so this led us to looking at where and the fluidity of the virus, but the South Bay has been adversely impacted. We have more dense housing population. We also have our issues of a lot of essential workers in that area. It's also its proximity to our border. We have the very active border crossing. And so a lot of factors in that community. So it was clear when we looked at our testing, next slide, that we developed what we call our South Bay saturation strategy, working with the mayors, working with the cities, working with non-elected community leaders, working with our equity, community equity task force and our Filipino equity task force, working with groups to help us define where best to provide sites, whether it's a school site, a community site, a parking lot, one of our county sites. We looked at a whole array of sites, and again, that earlier side of looking at the strategy diversification of our testing of different places. Rural areas, we had to be more mobile to get to all the areas versus more, as you can see, that concentration of our central and south, which are stationary more sites. Next slide. As it moves then to the next T, from testing to tracing, for when someone, and we start always emphasizing the importance of when they come in for a test is linking them to a medical home. And if they don't have a medical home, we work with our nurses to make sure they have a medical home. Because if they have a positive test, they really need to be tied to their medical home, their clinician, about their unique care. We follow that up with our disease investigators. These are our case investigators. These are the ones that immediately, within 24 hours of a case positive, trying to get there immediately to have that investigation with that person so that we can then follow up their immediate close contacts and folks that are at risk. These are the contact tracers that go on. We took it a step further in San Diego, and we said we also want to have the trusted messengers, knowing that some parts of our community are not going to engage with someone calling them about interviewing them on the phone. We actually developed something we've had long-standing in San Diego, is our promotoras. These are community health outreach workers. And we've had our graduate school public health. We gave them funding to recruit them. It's about 80 of these promotoras, and they're assigned in the community, working with our team, and they being more in the community. Again, trusted messengers going through a training of how do we engage with people so that we can, unfortunately across the nation, have a high failure rate of people responding to those case investigators when they make those calls. We wanted to narrow that significantly. And we do fairly well in San Diego, and I think it's because we're taking this more holistic approach. Next slide. And then wrapping up on Treat. And as I mentioned, Treat for us is not only providing a hotel room, we are also working in our convention center in downtown San Diego. Currently 1,200 of our homeless, unsheltered homeless are housed there, have been there several months. It's a partnership with our city of San Diego, our county team with our public health nurses and behavioral health, and our regional task force for the homeless that provide care and shelter for a highly vulnerable population, which includes now testing that we have on a regular basis for that population. So we're thinking about Treat as who are we treating in the individual in the public health room to a big congregate care setting or homeless shelter, and also now our expansion of not only remdesivir, but also convalescent plasma. Work with San Diego Blood Bank of promoting and collecting plasma donation as a therapeutic for us here in the region. That's part of our T3 strategy. Next slide. So this is the dashboard. We, on a daily basis, this is an operational strategy that begins to tell us how we're doing. It goes much further in detail, but we roll this up. We share everything openly. We have it used to be 5 days a week, now it's 2 days a week, where we have a live press conference for our community. But you could see the metrics for us We were given by the state a metric of achieving better than 5,000 initially in our rollout. This was the state plan, as Dr. Wooten said, with now reaching 6,600 tests. There's a methodology to that, 2 tests per 1,000. We're far above that 6,600 benchmark in our latest phases of reopening. You could see as of July 19th, we're almost 8,000 tests, and our 7-day average, which you look at, is almost 9,000. Over 500,000 tests. These are cumulative number. And then our tracing of where we are with our number of staff, which is important, but importantly, the case investigations you'll see of over now approaching 28,000. To how we're also looking at the number of people we're serving in our public health rooms, of being as high as 200 to currently at 82, and then the cumulative number we have served. Next slide. So T3 is as good as the relationships we have. And again, as I said from the top of this presentation, we were blessed beyond blessed of building a decade and beyond with relationships in our population health sector. And right from day one, on Valentine's Day, when we declared our public health and local emergency, we activated our sectors. And Carrie Catelli, our Director of Strategy Innovation, who overleads the Live Well backbone and framework and works with our partners, and we'll talk about that meaningful work of how we went about engaging with our stakeholders throughout the county. Sure.
Great, thanks, Nick. Yeah, so as Nick mentioned, Live Well San Diego is the county's vision for a healthy, safe, and thriving region, and really it's based on the premise that no one entity, whether it's the County of San Diego or others, can really address public issues alone, and certainly that's the case here. We really do rely on the contributions of our partners and other stakeholders to align to a common agenda. Early in this pandemic response, we knew that education and outreach was critical, and we knew that the best way to activate immediately to reach our partners, our stakeholders, and really the 3.3 million residents of San Diego County was to operationalize this Live Well San Diego network. Interestingly, you'll see there we have 493 recognized partners at the beginning. This was pre-COVID. We were on our way to recognizing 500, our 500th partners, and these are organizations and entities that came on board in support of this common goal. And so with our 16 of our 18 cities and our unincorporated areas, with 39 of our 42 school districts and many of our other partners, we knew we already had the mechanism in place to reach much of our region. So the existing structure and network of Live Well San Diego really did lend itself to an immediate response and activation for education and outreach related to this pandemic. And so you'll see there on the slide the 4 initial Live Well San Diego sectors. We have cities and government, business and media, community and faith-based organizations, and schools and education, that we convened those initially and then quickly expanded, quickly expanded them to additional sectors and subsectors to meet the COVID-19 related needs of our community. And this slide really shows you all the different sectors that we have grown to. So these expanded sectors include older adults and disability providers, long-term care and residential facilities, the laboratories, community-based organizations, and faith-based organizations, which also includes our youth sector and our rural sector. Government, which includes the city managers from our 18 cities and from the county, which oversees our unincorporated area. Our binational leaders, our local, state, and national legislators that represent our region, and leaders from our 18 tribal nations. We have business here, which I'm going to talk about in a little bit more a little bit later. Education, with the focus on areas of early child care and education. We have K through 12, as well as colleges and universities. Military and veterans, homeless and shelters, and then healthcare, which was also not just our dental providers and our clinics and centers, but we also hosted clinical town halls, which were for area physicians, and these were held in partnership with our hospital association as well as our San Diego Medical Society. So in terms of structure, each sector team is comprised of a sector lead and co-lead, a medical subject matter expert, and sector support staff. And those sector leads are managers and or county executives who really are subject matter experts in the area that the sector is focusing on. And then they have a co-lead to help manage the team of full-time, for the full-time operations of this work. Public Health Services clinical team under Dr. Wooten's leadership really serves as our subject matter experts for the medical and public health field. And they're assigned to each sector and provide guidance to the sector teams as they respond to questions through the telebriefings, as well as helping to guide the development of our education and outreach materials. And then we have sector support staff who are actually county employees who were reassigned from their regular duties to support the communications and operations of the sectors. Our communication strategies implemented by these sectors include regularly scheduled telebriefings. These are actually on using the Zoom platform, and they tend to be weekly, and we'll talk a little bit more about that. Ever-growing email lists with weekly e-blasts of timely information and key updates. Sector-specific web pages on the county's coronavirus-sd.com website. Maintaining and updating the frequently asked questions that are specific to each sector, and then managing a sector-specific email account that stakeholders can submit questions for actually specific and very direct responses. And then we also conducted a number of community presentations, usually upon request, and of course using the virtual space. But it also included responding to requests for presentations in the community, at different speaking appearances for other groups, included radio and television interviews, and so on. This next slide gives you a little bit of insight into some of the averages that we're seeing over time since we launched this education and outreach component. So on average, the sectors have provided 15 telebriefings per week, have an average of over 1,500 participants, 10 presentations per week with over 400 participants each week, and e-blasts with over 13,000 recipients each week. This next slide is just gives you, again, sort of a glimpse over time. As we adjusted for a longer-term response, we did solicit feedback from our participants in each sector. What we wanted to do was really assess the value added and adjust accordingly, so we knew that we were meeting the needs of our stakeholders. So this has included several sectors moving to an every other week schedule rather than a weekly schedule. It also included adjusting, so instead of the larger group convenings, maybe doing some one-on-one sessions or some smaller group workshops to meet the specific needs of the sector, and then other similar types of adjustments that we've been making over time. And so although all of the identified sectors were important to engage, we knew that enlisting our business leaders and associations and related groups would be key. And so we knew that there was an opportunity for not only for them to serve as a conduit of information to their members, to their stakeholders, to their constituents, but also for us to be able to gather information. They serve really as an important source of feedback and guidance, and really helping to identify opportunities for improvement in this work. So some of the additional strategies that are specific to businesses and employers is we engaged a group of professionals that's called the Business Alliance Network. And they really provided a lot of technical assistance and consultation in the development of that sector in particular, but even specific things like how is the web page laid out? What does the email blast look like so that they're most meaningful to the recipients? We did personalized calls with all 33 chambers of commerce around our county and the business improvement districts to find out, well, how are they managing through this pandemic? How is information being shared, and how can we better support that? We attended meetings of those business organizations, so really meeting them where they were at and leveraging their networks to get our messages out. We set up a dedicated reopening web page that includes specific guidance on reopening and listing the types of businesses that could and couldn't be opened, and addressing those specific questions. And Dr. Wooten did provide a series of different guidance letters on behalf of the public health to chambers of commerce, to business districts, to employer groups, and others. Next slide. So as this is a full-scale, all-hands response, the Education and Outreach Branch was able to leverage the resources and support from our coordinated media and communication efforts. And this is through Live Well San Diego, this is through our county communications office, and this is actually also through our Joint Information Center, which Dr. Wooten mentioned when she shared the structure, when we activated our Emergency Operations Center. And as everyone knows, with the COVID response, information is actually changing daily, sometimes multiple times a day. So it was really important to have a direct tie to our media and communications assets. This was critical to ensure that we were getting the right information out to the right people at the right time. A few examples of some of the special campaigns that we launched. We launched a professional marketing campaign early on that included some public participation. You'll see on the left side there, people holding up their signs, to reinforce our stay-at-home messages. And we're now adjusting this campaign to have stronger messages that are related to face covering and social distancing, physical distancing. We launched Live Well at Home, which is an effort to ensure that as San Diegans were physically distancing, that they were still connected socially and had connection to resources and supports virtually. And we've had over 105,000 visits to this webpage since it launched in April. And then our Live Well San Diego 5K, which is an annual event each summer that draws thousands of participants. With our current situation, we were actually able to pivot, and we're now hosting a virtual 5K on August 16th, where participants can register for free. They walk or run and in their own communities in a responsible way, and then they post their results as well as a selfie at their own finish line. As of this week, registration's only been open for about a week now. We have over 830 registrants for this event, so we're looking forward to that next month. Both Nick and Dr. Wooten mentioned the focus on our equity lens and really using that to guide our efforts and really ensuring that the needs of our vulnerable populations are being met. From the education and outreach perspective, we hosted a series of focus groups and listening sessions. And we identified these particular populations so that we could align efforts and ensure that all residents had access to information and resources to stay healthy and safe, and really including a focus on the trusted messenger models, and Nick touched on that. So just, some of these groups, we talked about the Latino communities, homeless. We actually paired public health nurses with our homeless outreach team. And they conducted screenings and disseminated almost 10,000 personal hygiene kits during this time. Older adults and disabled individuals, we have our aging and independence services that launched a state program, Great Slates Delivered, and have provided over 225,000 meals since the start of the program to over 1,800 clients who are served 3 meals a day from our local restaurants. We identified refugees and immigrants, and we've activated what we call as our program called Partner Relay. And this is a network of over 450 immigrant and refugee serving organizations and businesses that help ensure communications go out linguistically and culturally appropriate manner. In our rural communities, we've had partnerships with community-led associations that established as well as our first responders, which are actually key in terms of outreach and connections in our backcountry communities. And then we launched the Youth Emergency Readiness Ambassadors, or YERA program. This is where we've hired 22 youth aged 16 to 21 to work with emergency managers throughout the county to develop and disseminate messaging to youth. This next slide just kind of highlights some of our key outcomes and tools that have been developed in this short amount of time. All of these and many others are actually on the web pages for each of these different sectors. The homeless sector developed a universal screening tool to help determine when homeless individuals needed medical referrals. We've got the pediatric provider toolkit. Like many jurisdictions, we noticed that child visits were going way down, and we wanted to make sure that medical providers and pediatricians had the information that they needed to encourage those visits. And then with the kind of the derailment of high school graduations, we put together a Safe High School Graduations Guide in collaboration with our County Office of Education to promote drive-through graduations. So all that information is on there. And then this last slide, just kind of a glimpse of what we're, some feedback. And we know our community values transparency and communication, being able to really adjust this framework. But in all honesty, we really think, and in conversations with some of our county leadership, we understand that by putting this framework into place quickly and being able to adjust it as needed, that we believe we've prevented what could have been an overwhelming amount of questions and inquiries through our own county offices, and possibly even a more negative response from our community. And we will continue to gauge feedback. We'll continue to get input from our constituents, from our stakeholders, from our participants, and we'll adjust as needed for this long-term response. Back to Nick.
Thank you, Carrie. You know, it's wrapping up. It's hard to talk about lessons learned because we're feeling like we're still learning. Mm-hmm. And we were, as a team, talking about, you know, what is it that we think would have value to share? Because as I said from the onset of this, is that we're eager to learn from you, and this is really more of a virtual conversation, kind of a fireside chat about how we're helping each other. But these 6 things stood out, and Dr. Wooten really emphasized, and it's really key, is that you know, we are a matrix organization for the Health and Human Service Agency. We're a big organization, about 6,700 employees that deals with health, housing, and human services. But when it's a crisis, you really do need to have a very clear incident command structure that is functional as to delineate who does what, because you're really having speed and accuracy, if you heard Carrie talk about, matters immensely. And so we were blessed because we've had so many challenges, both environmental, from fires, as Dr. Wooten said, to Hep A crisis and other things in the past, that we were, with ease, really implemented this kind of structure coming in. And the team, although operationalizing new approaches really to COVID, there are things that what Carrie talked about is primarily something new in our response, and even in an incident command model. And bringing together then the policymakers, county leadership with our public health officer, Dr. Wooten, and then many others, in being clear on how we're making those evidence-based decisions, almost sometimes on an hourly basis, it feels, are very important. And those are connections we think that we have worked hard on in establishing for us. I can't emphasize enough about the health equity. For us, it's been natural because of Live Well San Diego, we take a whole person approach to well-being. So it was clear to us from end to end of how we were going to do this was not just protect lives, but knowing that we were dealing with severe trauma, mental health crisis of a large population, all of our, our whole nation, and how we were addressing that from the physical to the mental well-being and what we could do, and knowing that it could not be government alone. And the natural about obviously using the Live Well model in our sectors of the relationships. I can't stress enough with that. Thursday, I'm speaking to our largest Chamber of Commerce, the San Diego Chamber of Commerce, about a partnership, about reopening. And it's wonderful when you have, and not everyone's on the same side, not everyone's necessarily happy about, for us dialing back, and we can go into the questions, but they value what the public health officer is sharing, and they want to learn what is it we can do together as partners. And that's the conversation even on Thursday with our largest chamber with 3,000 companies here in San Diego. One other aspect we called out, and this is Dr. Wooten, our resiliency officer, and how we brought in thinking about resiliency, thinking about reopening, and brought in our resiliency officer to lead our safe reopening plans through the state, working closely with policy and Dr. Wooten, has really been a blessing for us and something that new in our response. And then we'll wrap up, and again, by all means, there's many more, but these are the main 6 that came up, is the fact that clinical leadership was so key. And so subject matter experts we needed, but we didn't have a physician for every single sector dedicated. So we had to use our public health physicians to cover a number of sectors. And the addition of our having under Dr. Wooten, our physicians, working closely with our sectors, providing real-time clinical guidance was really invaluable for those sectors, meaning not having to further delay getting back, but having those subject matter experts there. So again, these are the six major. There are many more. I think we'll get into, Meg, into the questions a lot more that we can be happy to drill into. But as we close, and just thanking you and hearing our San Diego journey, knowing we are still early into this journey, long way still to go as a county, as a state, as a nation. But hopefully this provided some insights that may have some value for the audience. So with that, Meg, I'll turn it to you.
It helps if I unmute myself. Thanks very, very much. You know, what I would say is both the capacity and the transparency and the trust that, would be the three items that I would take away from this. And I encourage others to ask questions. Let me start maybe with one very much on where you had just left off with regard to, you talked about how it is that you engaged with the Business Alliance and with specific business groups. What exactly were their roles? Were they addressing community health issues? Were they focused predominantly on their own employee health? And to the extent they were involved in what we might call community or population health, what specific programs, activities were they providing?
Thanks, Meg. Great question. I think I'll answer this together with both Carrie and Dr. Wooten. So we have to bring it back to pre-COVID. The relationships we have with the business community was tackling a number of issues. One that comes to mind for us is heart disease. And for us, that chronic health condition was one that we needed to enlist the support of our business community. And so for the last decade, on Valentine's Day, something beyond declaring a public health emergency, we hold our Love Your Heart campaign, where we provide free blood pressure screening. And we enlist the help of businesses to do that, to help their members, right, their workers, perhaps their customers. And so that's a prime example of the trust relationship of what we were tackling on something that went beyond just what public health could do alone. And so when we shifted, obviously then to COVID, then it shifted up, what can businesses do? They wanted to know, what can they do? And there was a number of things, clearly from the Dr. Wooten will share, to then more technical things that were unique to their industry sector. But you mentioned the Alliance. I'll turn it to Dr. Wooten, and then Carrie will talk about the Alliance.
I think the most important thing from our perspective of what we could do first for the businesses was to educate them about the latest guidance that had come out both from CDC and from the state. So that started with a general letter that went to the various sectors, whether it was business, healthcare, long-term care facilities, or community-based or faith-based organizations. So that was the primary focus, and as things progressed, convening the sector telebriefing so they could ask questions, and we could clarify any misunderstandings or information that was currently available to them. And then also, as Carrie stated, making sure that we provided newsletters or a web landing as part of our website where they could go and get needed resources for them to carry out the guidances that we were asking them to carry out.
Yeah, thank you for that. And then I think it was a little bit different early on than it's evolved to now. Mm-hmm. So early on, it was very much about, okay, what do you need to know? What are the resources that are available? And not just county resources, but what are those state resources? What are those federal resources? And because there's so much information flying around, that those business sector partners really helped to align that information. We had guest speakers that came in early on from San Diego Workforce Partnership, the Chamber of Commerce, so that it wasn't just the county speaking to them, but it was their own trusted messengers that were helping deliver these messages. And then as it evolved, it's really been about tapping into their expertise on how to best communicate with their colleagues. Many of especially with the Business Alliance Network, many of those participants and members had experience in emergency response. So how could they take their experience from a business lens and share it with others throughout this sector? And then we did have the opportunity to get a little bit more specific. You know, there's no one size fits all for any of this, but particularly in the business sector, you have large versus small companies, you have urban versus rural, you have all these different constituency bases as well. So we were able to pivot relatively quickly and say have a special telebriefing or workshop that was just to I've got to get it right, it's called the professional body art industry, or something. Basically tattoos, piercings, all of those folks wanted to have a specific conversation because those businesses are operated quite differently than, say, a restaurant or others. So really trying to be mindful of what their immediate needs were, but understanding that they absolutely were the experts in communicating with their own colleagues.
I can say another example. Carrie is absolutely right about the personal care, body art community.
Yeah.
We've had several meetings with them once the guidance came out, but also as we identified outbreaks in food manufacturing businesses, we sent out information directly to those type businesses so that we could educate them about what tactics and strategies they could take to decrease COVID-19 cases and to decrease outbreaks in their particular facility. So as Carrie stated, things change, and as new things occur, particularly with cases and outbreaks, that helps to direct our actions and focus on certain business aspects.
One thing that our public health officer, Dr. Wooden, did that may differ from community to community, but was pretty heroic. She refused to publicly shame or name businesses when there were outbreaks. And the pressure from media at our live press event and the relentless of tell us where the outbreaks were, tell us, and we wouldn't do that because we would lose the trust of working with the businesses because it was no fault in many of the businesses when there was an outbreak. So the ability to stand and get tremendous amount of criticism by our public health officer, standing on the side of partnership and good science in public health to say, that won't help us, that will hurt us, is another example where I think it really built that partnership with business.
And let me follow up on that because you've talked about, I think, two critical forms of trust. One is trust with partners, and the second is trust with residents in the community and those trusted relationships. You know, at some point, hopefully for all of us, the pandemic will, be lessened. Can you talk a little bit for those on the call and others as to how you can assure the sustainability going forward, that those relationships, I'm thinking, Carrie, of your graphic of the many different new partnerships you formed, what's the glue that's going to keep those partnerships sustained as you try to reach out and address even broader issues?
Yeah, that's a great question, and I think it comes back to our original opening remarks by Nick, that it's really about the Live Well San Diego framework and the vision that we already had in place before this and that will continue into its next decade ahead of us. I also touched on the comment that there's no question, and we've learned this in our 10 years in operationalizing Live Well San Diego, but now more than ever, our partners and our residents value transparency. They just want to know what they need to know and be honest with us, give us the straight information, and we'll figure it out together as we go along. Don't, come off like you're hiding things. Don't, on a need to know basis. No, let's just get information out. And, You know, Nick and Dr. Wooten talked about, you know, the daily press conferences and all of the different mechanisms we had in place to put information, make sure it was getting out there. The other piece too, and Nick touched on this, is the, you know, the community health workers, the trusted messengers that are not only from the resident side of things, but that's absolutely the strategy we use within the sectors, right? It doesn't make sense to necessarily have one of our county executives be the sole voice for faith-based organizations. It makes sense for us to engage those faith leaders that are clearly on board and doing it right as a role model for the rest of their sector, to be able to continue to share that information, not just for COVID, but beyond, as we're continuing to look at, you know, the different issues in general. But, you know, as this becomes this longer-term response and all of the ramifications of what this is, you know, and what our community is enduring, I think there's going to be a lot of opportunity to, you know, now more than ever, make sure that we're working collaboratively together with our different partners.
And were there specific examples? A question that's come up is, you know, were there cases where, for what's called the non-pharmacologic interventions, was there actual pushback either by citizens or businesses?
Dr. Wooten earned the right to respond to this one.
and how did you manage it? Because I think that's something we've heard on our prior webinars has been an issue, and different communities have dealt with it differently. So your perspective would be, you know, I think very, very helpful.
Well, we've gotten hundreds and hundreds of emails, and let's understand and be clear that you're not going to please everyone. For as many people as we have that are dissatisfied with the facial covering order, other people are supportive. We just don't hear them be as ferocious in expressing their agreement as we do the people that do not agree. And so when we get these types of emails, first of all, don't take it personal. And then second of all, we try to turn that into messaging that we can include in our briefings to educate the public. And in the case of the facial coverings, we created an infographic that provided the science about why we were recommending and why the state and why the CDC. In January this year, no one was recommending. Even if you had asked me in January, people did ask, and we said no. CDC doesn't recommend it. The state doesn't recommend it. But once the evidence came available, then we made the recommendation based on the evidence. So again, it speaks to that transparency and taking the information or emails from naysayers and then putting it out there in a positive framework to educate the public in general.
You know, Meg, it's a great point. This is every public health officer across the country is dealing with this, and it's a challenge. You know, in our line of work, particularly population health, we know that visionary leadership, right, is seeing what everyone is seeing and doing what no one else is doing at the cost of mockery by the present for the betterment of the future. Mockery lane is a really tough place to be alone. Really, for us, we were not alone. We were going through mockery lane from those that disagreed and mocked the public health orders with a large number of people, and this is where the sectors and the partnerships mattered, because it wasn't just the hospitals standing with us on science and public health. It was non-elected community leaders, it was faith leaders, it was all those sectors that were truly reflective of the community. There's a comment, I think, from Ray on the board, on the chat, about trust of the community. It's so key. And you know how you've built that trust when you have a crisis like COVID-19, where you're giving a very difficult message, and there's others that are enforcing it with you.
Mm-hmm. And in terms of, in terms of difficult message, I think one of the things that comes through from your slide on the data on demographics, is, and as you've talked about, what you've done is use the health equity lens to look at the impact of COVID. A question that we've heard over and over again is that COVID pandemic has really revealed some critical fault lines, some health equity issues. So as you see the impact, as you've tried to address these already, what are your lessons looking through that lens as to where you see maybe priorities changing for San Diego or for Live Well San Diego, new approaches? Just where do you think you'll be going now that this data is sitting in front of you with regard to these issues?
Yeah, great question and point. One that really stands out, and there's several, Meg. One that stands out is when we were seeing, encouraging people, for instance, to come and get tested. Again, it's free, it's available, there's no copayment. I remember our mayor from National City in South Bay, where we have higher prevalence of cases, having a conversation with her as to why we're not getting more people. We're getting a fair number, but why weren't we getting more? And it stood really, it's something we've known. And she said, well, they're worried about getting the result because they don't have a place with their family where they can safely quarantine and self-isolate. And so when you're dealing in communities where, in particular communities with poverty, and don't have the type of housing supports, don't have a place where they can go and say they don't have a basement where they can safely isolate for 14 days. They were not even getting that test and that fear. And I think that anxiety, right, that's a big issue for us. So the housing insecurity, or how we're even seeing now for the displaced homeless. We have a huge homeless problem in San Diego. Going forward, we know we can never go back to the overcrowded homeless shelters. That's why we removed them. So there's a new normal of how are we going to address that housing security with great urgency, because that convention center will have to eventually come back online. And so housing as health is something that your Action Collaborative has clearly focused on, is clearly a high priority for us, and one that the cities with us are trying to address with housing now currently for the homeless. We, the county, with our public health rooms, because hotels weren't being used, we've secured those. But what happens when hotels come back? We don't have all those rooms for folks where people can safely isolate. So that is a big issue we're addressing now. Has to be one that's addressed with all the cities and the unincorporated areas for us. So that stands out for me. Dr. Bloom, if you have any.
Maybe a follow-up question. I know, as I sit here listening, awed and a bit overwhelmed by both what you've been dealing with, but the capacity that you have been able to bring to bear, including new operations like a medical operations center, the collaboration, the decades of history that you have for public health departments and private sector collaboratives that aren't yet where you are, but have the same motivation to make a difference and to really grapple with the COVID pandemic on behalf of their residents. What are the essentials that you would encourage them to focus on? The essentials and the kind of the minimum sufficient they should take away from what you've done.
Well, I'll start to try to address that, particularly for smaller jurisdictions. Everything is about relationships, and in smaller jurisdictions, people know each other. I know that my colleagues that are from smaller jurisdictions have a lot of interaction with elected officials. They might go to the same church or just know each other in general because the community is smaller. So leveraging relationships and just starting somewhere. where you have the greatest relationships, and then expand as you can, but start somewhere based on relationships that are already in place. That would be one of my first recommendations.
Yeah, I echo that. I would add, Meg, that in smaller jurisdictions as well, for us, we were already an integrated health and human service agency with housing, so there was a more natural in how we were bringing in dealing with food insecurity, or dealing with homeless, or dealing with aspects of our COVID response with human services. And so silos really don't work when you're dealing, right? The COVID-19 doesn't recognize silos. So we, particularly for smaller jurisdictions, my advice has been that is a time, if you haven't been coming together, you really do need to come together, not just structurally, but more functionally, because you have to leverage your resources that are pretty tight.
This is going to sound incredibly simplistic, but sometimes simply asking. We found so many people that are organizations that weren't necessarily part of Live Well or part of our efforts prior to COVID, that simply by asking them to participate, and they are eager to they want to lend their support, they want to lend their expertise, just by asking them to engage in the discussion and in the effort helped really solidify some early and long-standing in these 4 or 5 short months, was really, it seems, oh my God, it seems long. So that was, and then, certainly we have the backbone structure that's supported. You can't just invite people to the table and not, have some sort of an ongoing approach to this, and having the backbone structure to be able to support virtual meetings and, action items and follow-up and making sure that, that things are moving forward. But it really so many times came down to just asking them to participate, inviting them in.
Can I just add that the framework for Live Well San Diego with the partners, it really is premises on those 4 sectors. And just in general, during COVID and even post-COVID for jurisdictions, focusing on those 4 sectors, something, because I'm sure there is something each of those 4 sectors can benefit from, and we could benefit, or the jurisdiction can benefit from their engagement. So going forward, but start with businesses or start with schools, but is just start somewhere. Yeah. And then it can expand, mushroom.
Mm-hmm. And one of the things that's very impressive about what you've done is really to be able to have that transparency and the communication about the statistics and the metrics, the data, at the zip code, at the age and so on. We heard on last week's webinar that there seems to be some real challenges that county health executives are facing in terms of collecting and disseminating data. So again, in the same vein of what I just asked you, what from your experience in the data and the metrics you're tracking and publishing or providing, what's been, if you're talking to a smaller jurisdiction or someone's trying to make sure that they stand up the best data now, what would your recommendations be?
Well, San Diego is grateful to have a very robust and dedicated staff, even though for our population, it could be larger in that respect, but we have excellent staff. So the focus on getting information out there for the cases and just the basic surveillance information, number of cases, the age range, as well as the race and ethnicity, just beginning to share that information, I just think is important so that the public knows what's going on and that they know that you are being transparent with the information that is being collected.
Yeah, Meg, I think it also builds on how you set the tone, and our tone about trust of that we would not do harm with the data that they share, but the opposite, right? So there was a you know, a sense that the collective public good of the data was being valued, being protected, and it wasn't as much a difficulty with true candor. I think it goes back to because we were doing our external dashboards around things like life expectancy and very difficult things as well, and people sharing that data. So it did help in having that relationship. But we came across, come across the folks that didn't want to share because it may make them look bad as the entity. And that's, again, working with those institutions about looking at the aggregate, because we needed that data to guide us. That was very important. And we were all in it together. And so that kind of approach, we're all in it together, really lent more of those willingness, even for those that initially said no, to open the door and share that data.
In going forward, you know, it's clear that in San Diego, as in every community in the country, the next 3 to 6 months are going to continue to be a challenge, and, you know, for somewhat the longer term too. Where do you see your efforts going, perhaps with regard to thinking about the longer term implications down the road of access, health status, chronic conditions, but even just the kind of economic resiliency of the community? You know, what are your insights for kind of where you might go there that would be useful for other communities to hear about?
Yeah, that's an excellent question. I worry immensely about not only the economic disparities that we're already seeing and we'll see further, but it's also the challenges on mental health and the access of quality mental health. So one of the things, because of COVID, having to move into a more robust mental health kind of environment, the blessing in that, though, is it has now allowed us to scale that more broadly and make it more available because of the new service delivery platform, meaning we're rethinking already now of how do we serve our population, knowing that we'll probably get a larger safety net of people in need of health and human services. And how do we rethink now with how we're designing our services, i.e. mental health, that we can make it more cost effective, but more readily available with our partners. That's an example of meeting the need today, but thinking into the near and far future of how we're going to need that growing number of services that we're going to have to do with our partners. So that's kind of our resiliency of our behavioral health group that's doing it. We're looking at that same approach in terms of our workforce development group, our child welfare group, and candidly, even in public health, how we're doing that. So housing being the other issue, knowing we'll have greater displacement of housing and housing insecurity. So how are we working with our partners on that? So I think there's things that we're already in addressing the COVID planning now, Meg, of achieving that. And the mental health is the big one that I'm involved with. I don't know if Carrie.
Yeah, I'll just add to that, back to the framework of Live Well San Diego lends itself to really being able to pivot in this aftermath of COVID and where are our priorities. Nick mentioned when he was describing the framework, it's building better health, it's also living safely, and it's also thriving, and that's where the economic and educational and those environmental types of components come into play. And so the framework's there, and there are existing priorities in there that together with our partners, we've all been working toward these goals and objectives. But knowing that we would need to really relook and reprioritizing using data to guide us, and Dr. Wooten mentioned our data team is incredible, and we do get regular data reports on our different indicators, being able to shift as needed to address some of these long-term implications.
Two questions and quick follow-up. One is just, a very big picture question following this. Do you see permanent system changes based on what your experience is. But Nick, to go to what you asked at the beginning, you've done an incredible job of sharing with us about the trusted partnerships you've built within the broader San Diego community. What are you looking for, or what do you see possible in terms of cross-community partnerships that could really help, replicate, sustain, give that systemic infrastructure that we might so desperately need going forward?
Yeah, great, and I'll have my colleagues join me, Meg, on that. So first, for the permanent systems changes, absolutely. We have 2 million square feet of owned and leased space for Health and Human Services and the services we render. That 2 million is going to be significantly reduced. Why? Well, because of being forced to be in this telework capacity. I gave you the example of telemental health, but the issue about even how we're engaging with the people we serve. Now, we serve 1.1 million San Diegans across all our programs for Health and Human Services, and we think that number will grow. But it's rethinking now of, well, how do we provide eligibility services? It reminds me of when we had in 2008 and 9 and had the drop in our economy, and we had still the old-fashioned come to our buildings to come in for eligibility. And we were overrun, lines around the block. And we had to develop a call center. We had to develop a telephonic signatures. We had to develop a whole new way of helping people get into public entitlement programs so they can get food or access to health care or access to jobs. It's that fundamental design here. And the great thing is that there isn't a fidelity to the profession, meaning I'm not getting pushback from all the different professional groups, be it mental health clinicians or child welfare social practices or public health nurses. Everyone's really realizing this is something we have never experienced in our lives. How do we now think about providing our services more broadly? So that I think you're going to see the more nimble, more agile, and frankly, a lot more virtual of our services. The home visits can't change. We're going to have to be in those home visits. They're not going to change. But there's other services that we can provide that actually will improve the level of services in our rural communities, for example, in our county. It's a type of more robust services. So that is, as we speak, things that we're working on in our county. As it relates to how do we learn together and share? Live Well Wake County, North Carolina, took our platform and they obviously customized it appropriately to their community. I think there is this collaboratory, and you with the population health sector and the National Academy of Science really enable that of how do we learn across jurisdictions. We are working with about a dozen different jurisdictions across the country that we're learning from, but they're taking parts of our model. So I think that's something we've been doing for years, Meg. That's, I think, something we'll have to even ante up more because we're all going to be trying to figure this out in the coming decade of our services. But that's something we're committed to doing, not just in our neighboring counties, but across the country.
Yes, I agree with Nick. In addition, social distancing actually will change how we interact across various sectors. It will change how office spaces are constructed to maintain social distancing. It will dictate or promote more telemedicine as well as teleworking, all in the name of promoting social distancing. So I think going forward, I've seen some reports that the whole open office structure is a thing of the past. And so the changes that it will develop are related to how we can have people maintain separation but still get their work done. And people not maybe even having office space but working from home. I believe that's going to be a major change going forward, as well as telemedicine. I think definitely that is going to be a change going forward as well. So right or wrong, COVID-19 is really going to bring about significant changes, all in the sake of social distancing.
Well, I thank you all. I see we're at the end of our time, and what you've managed, I think, today on this call is to, while we're all socially distanced, to really have us all be in one space. And, you know, we've learned tremendously from your experience, and thank you for sharing it. I am going to tell everyone that we'll post information by which they can send an email to you, following up, Nick, on, you know, and all with the conversation that we just had about getting additional reaction guidance thoughts back to you. But thank you. I think, you know, what you've done established trust in our community and gives us, you know, some hope that there is a true public-private partnership to be able to deal with this pandemic and the health issues. So thanks to you very much.
Thank you, Meg.
Thank you.
Much appreciated. Stay safe.
Thank you. And thanks to all the attendees, and particularly to my colleagues on the Action Collaborative. But be well.